Okay, we're just going to record a quick video on a Miller blade or straight blade. A Miller blade can be used three ways that I know of. I'm sure there could be more. The first approach would be just to use it like a Macintosh blade, in where it's inserted into the right hand side of the mouth, sweeping the tongue over, and then working your way down until you see the epiglottis. Unlike the Macintosh blade, you're going to pick up the epiglottis. And then head lift is fairly important with a midline view with the Miller for most patients. The next way, so the first is kind of working the way down the tongue, the same as you would do with a Macintosh. The second option is to take the blade and insert the blade really deep, knowing that we're into the esophagus, then lift the head up, look down the lumen of the blade, so we inserted the blade to the right, down to control the tongue into the midline, and then we just slide the blade back until the glottic opening falls down into view. That's the second option with a Miller blade. Now the third option is the one that I found most useful, particularly for patients that have spinal restriction, also for patients that have high thyroid cartilages, so they measure a thyroid bone of like one finger or less than two. The approach with this is to get way over into the cheek. What's called a molar view is that you sneak way over into the side and you work your way down. You can use you can have an assistant pull the cheek out for you, but you're going to work your way down the tongue or pull it, and you can get over. And the advantage of this technique is that you can level the blade out more when you're in viewing without running into incisors. If I was in the midline, I'd hit the teeth, but way over into the cheek, so I'm kind of diagonally across the tongue. The tip of the blade is at the larynx, of course, at the epiglottis, but the base of the blade, where my hand is, by the handle, is going to be way over into the cheek, which allows me to level the blade. So if I'm in the midline, if you were seeing me in the midline with the head down, this is the position. That's a view that I could get. I can get a 2B view, but if I sneak way over into the cheek, I can get a nigh onto a grade 1 view just by coming over into the teeth. Now you need to, over into the cheek. Make sure that you're not hitting the teeth on that side, and you can have an assistant grab that cheek and pull that out. Now once you have this view, you're gonna take a bougie, is what I would recommend, and advance your bougie into your glottic opening, and then go ahead. Now that's a very small barrel. You kind of with your bougie, but it facilitates quite well. So once you lift that bougie, put that bougie down, then we can take our endotracheal tube and advance the endotracheal tube over the top. So three ways to use the bougie, or three ways to use the straight blade. The first would be just like a Macintosh blade, with the exception that you pick up the epiglottis, so you work your way down the tongue and then pick up the epiglottis in the midline. The second way is you insert it deep into the tip of the blade into the esophagus and then pull back, waiting for the larynx to kind of drop down into view with appropriate amount of pressure. And the third, which I'm a particular fan, and is a great practice if you don't have video laryngoscopy for a patient with limited C-spine mobility, is to get way over to that cheek, what's called a molar view. And there's a video there in your lesson plan around the V-scope and how to use that with a molar view. So I hope that's helpful to you as you approach use with the Miller blade.